morning and welcome everyone. On behalf of the Center for Spirituality and Health, we welcome you to our monthly Grand Round series. We're delighted to have you here today. Just a few announcements before we begin. If you have electronic devices that make sounds, if you could put them in a non-sound position, we would appreciate that. And by way of announcement, next month for our Grand Round series, which will be Friday, May 20th, we have Dr. Christina Pukowski from the George Washington Institute for Spirituality and Health, who will be joining us to talk to us about implementing or integrating spirituality into medical education. So a notice will go out about that. Be sure to save the date on your calendars. But today, for this morning's Grand Rounds, I'm delighted to introduce to you one of my colleagues. This morning's Grand Round speaker is a native of East Harlem who has spent over 25 years encouraging and counseling people as a community advocate, a licensed mental health clinician, and an ordained itinerant elder in the African Methodist Episcopal Church. She earned her Master's of Science in Pastoral Counseling from Loyola College and her Master of Divinity and Doctor of Ministry degrees from United Theological Seminary. We're very proud that she completed her CPE residency here at Mount Sinai in the Heart Hospital and currently serves as the Community Liaison and the Acting Director for the Department of Spiritual Care. Today she'll speak to us about the role of the hospital chaplain in the community. Please welcome the Reverend Dr. Zorina Costello.
Good morning, everyone.
Good morning.
Welcome those from the Mount Sinai community and those from the community at large. My presentation will be up in a few moments, but in the meantime, I did want to start off by speaking in very general terms about the presentation and go from the more macro view of the work that we've been doing as a Center for Spirituality and Health, led by Dr. Deborah Marin and Dr. Von Sharma. This presentation will invite you to understand that faith-based organizations are real and human institutions, and that healthcare institutions really are at the dawn of highlighting assets of congregations through programs of consulting, education, research, and publications. At the same time, there is an emergence of flushing out of the methodological lenses currently being used to engage faith-based organizations, as well as looking at issues of history, advocacy, social justice, looking at the social service ministries of congregations. Part of this is assessing who can help activate members of the community at large on a local level. Also, this kind of unearthing requires that we will identify simple and low friction activities that congregations do each and every day to reach out not only to their membership but to the community, such as having a church member or a ministry leader visit someone who is ill at home or in the hospital, or just, for example, honoring work that's being done by various members of the community. And by that honoring, that process of honoring the work and efforts of a congregation, it allows for a relationship of mutual regard to grow and to deepen. Out of that growth process, for example, this is a case where the healthcare institution and the congregation can share a commitment, and then that commitment can then be developed in serving the needs of the community's health. What is new about this relationship is that the hospital is not new to the congregation or congregations, but the congregations are new to the hospital. So in many instances, this is a new way of thinking about that relationship. And we're trying to figure out at a baseline level where we can identify population health needs in congregations, which have their own way of figuring out that there are health needs amongst their members. And they want change. They see that their change is needed in terms of the health care, the access to health, and being able to discuss the issues. But there's also a need in that synergy between the hospital and the congregations for the hospital to make some changes as well. In community engagement, we're strategizing about entry-level points to engage congregations, to engage the leadership, and to engage people about health conditions which are often complex and have further social implications. And being an academic medical center, we need to think very carefully about how we go about doing this. And so I'm going to start off here with the PowerPoint.
If that doesn't work, I can do it for you.
Okay.
Just give me the signal.
So for our agenda today, we're going to look at chaplains within the Mount Sinai Health System. We're going to look at potential for faith-based organizations to address public health issues and needs in the community. And we're going to look at co-creation of a design to improve community well-being. And then we're going to look at faith-based organizations and community-based organization partnerships with Mount Sinai Health System. So some key words here that we want to keep in mind are collaboration, faith-based initiatives. The one here at Mount Sinai within our department is MICA, called MICA. It is the Multi-Faith Initiative on Community and Health. We're going to look at some issues of health disparities, and we're going to look at community-based participation. And so within the Center for Spirituality and Health, we have clinical services, and we have education, research, and community engagement. And the driving principles of the center are to use evidence-based models, to document our methods that we use when we're working and engaging, to measure performance, and to review outcomes. So why are chaplains the people who are rather best suited to do this work in the community? And this is a new and emerging way of thinking about the role of a chaplain. So chaplains are trained. They've been working within this context. So we're pretty much going to stick to the context of Mount Sinai Health System, but we'll explore a little bit some other models. But within this system, we have, as chaplains, advanced degrees in theology, in ministry, and many other combinations of expertise from former careers and former education in fields such as psychology, counseling, social work, business, the arts, law, and allied health. A core commonality is that a chaplain has a commitment to provide spiritual and emotional care to others in times of vulnerability or crisis. And in the hospital setting, patients, families, and staff often seek out an extra layer of support from chaplains. Chaplains understand the importance of different faiths and religions regarding lifestyle, attitude toward illness, and medical decision-making. Chaplains understand the nuances of the culture of congregations. And when we meet with patients and families, we're really listening, we're actively listening for the differences, not only across cultures, but across religions, across lifestyles, across not only denominations, but there's sometimes individual differences in the same denomination from a congregation to congregation. So it's important for us to find out what those differences are, because we may be able to have an impact in listening to the patient and providing for those spiritual needs, and then also communicating that information to other members of the healthcare team that's caring for the patient. And so, within this context, the chaplains are board certified and/or experienced. They have clinical pastoral education, and we have students here that are currently here, residents and interns being trained. And in this context, again, we're using an interfaith model, although we're able to provide for a specific faith in many instances. And so we have pastors, we have rabbis, priests, ministers, and other traditions represented. And we also have specially trained volunteers that sometimes help with visiting patients and attending to spiritual needs. So, in thinking about the work that Dr. Martin Luther King did, particularly in the area of social justice, in many areas, but he also was concerned about the health of people. Dr. Martin Luther King, in addressing a medical committee in 1966, spoke about health care. Of all forms of inequality, injustice in health care is the most shocking and most inhumane, he said. And so, within that context and framework, we want to think about the important role of faith-based organizations, because Dr. King himself was a master at bridging those gaps between different community organizations and the people. And we know that of the religiously affiliated, 60% attend a church at least monthly. In some instances, obviously, much more. And that churches serve both their congregations as well as the community. So when we have organizations that are faith-based, and there may be a church, and in some instances it's an organization that is, their foundation is faith. For example, one organization represented here today, Friendly Hands Ministry, it's not a church, but it's a consortium of people that are concerned about the community, and they have different programs. They have a soup kitchen, they have housing, they have an array of services that they provide for the community, specifically here in East Harlem. And clergy can have a profound impact on the congregation. So not only the pastor, but whoever a pastor or a clergy leader has on their ministerial staff are people who usually have great influence in certain spheres of the congregation. So one person may be in charge of outreach, one person may be in charge of visiting the sick, one person may be in charge of programming, and all these people work in concert to affect the life, the spiritual life, and the behaviors within a congregation, and really help undergird the faith belief system, as well as having programming that's going to make their lives hopefully easier, and in our case, the part that we're interested in is healthier. And so, in choosing any model, and this is kind of the praxis from which we've been operating, it's important to partner with the community in high quality learning experiences. And we'll talk a little bit more about how we've been doing that. But high quality learning experiences means that it's meaningful to both the congregation and to any of the providers that come within the context. So we're actually going to the congregation to provide health, education, and some other services. And in those contexts, the faith-based organization is really the driver as to the needs of that particular congregation. But we are the bridge. As a chaplain and as the liaison, I'm a bridge between Mount Sinai and the congregation. And we want to encourage engaged work by valuing the assets of faith-based and community-based organizations. So early on in this process, this department has held clergy breakfasts, and some of you have attended those. It's been for 5+ years that those breakfasts have taken place. And within that context of the breakfast has emerged a group of people who are either pastors or members of ministerial staffs or interested congregants who just love coming to Mount Sinai and want to have these discussions about health and about different health topics. learn more about it and take the information back to their congregations and figure out ways to help improve the health of the people. So the assets that we've looked at and we took a survey to see what assets different congregations have. In many instances, they're providing some type of social service ministry, something that they've been doing over time, or they're providing a soup kitchen, or they're providing a elder care program. And so really valuing, looking at all of those assets within a congregation as something that we can learn from as an institution and that we can plug into and we can collaborate about. And we really want to look at the whole situation of collaborating and reaching out in a long-term sustainable relationship. Because there's been issues of trust, not particularly focused about Mount Sinai, but between communities that have not been valued historically, communities that have had some issues of abuse by medical communities. And so this historical context of that is something that is like the elephant in the room. And so we want to be mindful of that, and we want them to let them know that we're here for the long haul, that we want this trusting relationship to continue to grow and to develop, and we want to be intentional about the ways in which we connect with the leadership, not only with the leadership, but in many instances with members of the congregation, so that we can help them to connect to the resources here. Mount Sinai has a tremendous amount of resources in terms of the type of health programs that they can provide to the community. So through those trusting relationships, there opens up these avenues for exploration about what we have and what they need, and then that synergy is created where an interest is built, and maybe that can serve particular needs within that congregational setting. And so over time, we built relationships, for example, just a couple of examples, with population health, nutritional science, endocrinology, cancer prevention, advanced medicine, HIV/AIDS, infant and maternal health and access, providers that are helping people get access to care. And the important part of that is that when we partner with these various Mount Sinai departments that, for example, the Division of Oncological Sciences, they already have, over time, developed programs that are culturally sensitive, that are language concordance. They have outreach program called Witness Cares. They raise community awareness. They're health educators. They do colorectal cancer screening. They do Esperanza y Vida, breast and cervical cancer screenings, and then to follow up, they don't just go in and do the program, but they also have access for people who need it for navigation, referrals, and helping assist them to get medical visits, and then they check on them. They want to know outcomes, so they check on them. That department's here represented by Ms. Clarissa Martinez today. So our outreach versus engagement. Why the change in the terminology? An engagement model should be relevant and meaningful. So engagement means it's meaningful to both partners, but in a sense it has to be more meaningful to the faith-based organization. And it's just like when we as chaplains go visit a patient at the bedside, yes, the conversation obviously, if we're in ministry, is meaningful to us, but that's not why we're there. We're there because the conversation's got to be more meaningful, has to be more meaningful to that patient or to that family. So in this instance, there's a corollary there. The conversation and the planning and the collaboration has to be more meaningful to that faith-based organization than it is to us. So it's a pacing with the organization, with the leadership, with the life of the church, with the calendar of the church, with the decision makers of the church on how these projects are going to be co-created. There's a commitment to co-learning. As I spoke about, we learn about the assets, they learn about us, and together we're co-learning. We're learning how not only to work with them, but what's important to them, and how the health issues can be highlighted and addressed in more meaningful ways for them. And we're promoting equity, sustainability, and accountability together. So when we, for example, we calendar a program on diabetes prevention, it's important that the congregation have people in place that are reliable leaders so that they secure a place within a physical location within their congregation that's going to be the place where the program is going to be held. We discuss whether or not they might need any type of equipment for the program. We want to know anything, and we want to communicate with them if we have a provider, a doctor, a nurse, a nurse practitioner coming, that this is the type of situation that we have. For example, if we're working with HIV/AIDS prevention team, they want to know that within this setting there's going to be some privacy areas, because if they need to give results to screening, from screening, they want to have a private area where they'll be able to discuss with the congregant or the community member what the results were, and help them to have a follow-up plan. So it's accountability and sustainability and equity on both parts. It's a continual process. It's a continual dialogue, a continual conversation. The complexity of a church community, congregational community, must be considered in providing the framework for intervening. So each congregation is different. Some churches are smaller, some are larger, some have a few ministry leaders, some have key ministry leaders, some have administrative assistants that really serve, and some can sometimes, depending on situations, can block your access to that leader. So figuring out ways to navigate within a congregational setting in a kind of a nuanced way is important, and it requires skills that actually chaplains have, because when we're working within the hospital, we are providing a service not only for the patient, but we're also working with staff that sometimes is trying to communicate information. We may learn something from patient at the bedside that's going to be important information for that staff member, and we're negotiating these relationships in the best interest of the patient. And it's the same thing for these congregations. We're negotiating these relationships and getting them services and finding out about the different layers of leadership and the nuances of the leadership based on how we interact with them. And so it's through conversation, and it's through, it's actually through, in some interested, in some cases, being able to go and worship with them, letting them see your face, letting them hear you speak, letting them know that you care about this particular congregation. And so we're looking at church-based health promotion, and considering that faith-based organizations, for us, for this program, for the center, that they're essential partners. They're essential partners, and we're really sort of ambassadors, not only for the hospital, but in turn we become ambassadors for the faith-based organizations, because we have opportunities to interact with the various departments here and explain the needs of the congregation. So it's again that synergy going back and forth. And so again, we've had these monthly breakfasts with clergy or sometimes lay people who are interested in our various topics. And again, we have lots of opportunities, have had lots of opportunities over 5+ years to have interreligious dialogue and discussions of health concerns. And so there's a lot of kind of cross-pollination about ideas about hope, about health, about end-of-life care. All of those issues are at the table, and people take these discussions very, very seriously. For the breakfasts, they're small groups. They provide a safe place, and they give leaders a platform to explore health topics and access to experts in health education. And so these events have become a model, actually, for the type of events that can then be translated into the church settings. They know about how we do things, how we convey information, how we try to help them get access to certain services, and out of that, we're able to do a similar model within a congregational setting. And so some ways in which faith-based organizations do health promotion is through their health ministries. Some of them have at various times of the year, especially like this time of the year where the weather's getting nicer and nicer. They have health fairs, and that goes on all the way up until the fall. Many of them do health screens. Some have their own health rooms where they have equipment to take blood pressure on a regular basis. But then we also have teams that can go to the congregations and to the health fairs and do take blood pressures, cholesterol testing, the programs I mentioned in cancer, HIV. There's also opportunities for people to get in the community to get tested for Hep C. We try to do as much as possible on site. I mean, sometimes if we have programs here that are really valuable and interesting, we do invite them here. The Department of Governmental Affairs has also monthly luncheons that people from the community come to here at Mount Sinai. We have doctors and nurses that are invited to come and do lectures, sometimes as part of a worship service. The pastor wants to dovetail his worship service with this health lecture provider, integrating sermons that are about health, that may have some scripture related to health within a sacred text, and thinking about how pastors can use that, or some other members going in to provide a sermon. I've been invited to go to some churches and preach, and part of my preaching may be related to a health issue. We also provide written material, and we also have delivery of evidence-based disease management programs that come out of this institution. So there's a similar model that I looked at, the role of faith-based institutions in addressing health disparities, a program in the Bronx. Now this was not, there were researchers involved, but they were not chaplains. But they looked at mobilizing church members into health promotion and seeking equal access. So they engaged the leadership, they used the church structures that we talked about before for education, intervention, and trying to help the church make some changes in their own policy. And sometimes the change in policy can be changing the menu that your church is using when you gather together to a more low fat or low salt or less cholesterol menu. So those types of changes. Or it could be encouraging people to keep their doctor's appointments. I mean, that's something that oftentimes people have problems with. They make an appointment, something comes up, and they don't call back and follow through, so it could be something like that as well. But some of their key findings, and this is very condensed, but the importance of pre-existing relationships within the community are a prominent agenda, setting role played by key pastors. So pastors play a very, very important part. And the strength of the coalitions do focus on health and behaviors and health disparities. So when the partnerships are talking about health and also talking about disparities, because people want to talk about the fact that sometimes they feel they're not getting the same care as maybe somebody in the downtown Manhattan community, and why is that? And again, that's another elephant in the room that people are concerned about but don't have often a forum to discuss. And this is a consideration that there's a stronger collaboration, a stronger possibility of sustainability if you really are talking about not only the health behaviors, but the disparities that exist within the healthcare system. And so again, the open-ended, participatory nature of the intervention creates challenges in terms of measurement and accountability. Because from a scientific aspect, if you're very much focused on something that's quantitative, this model brings into account very much the qualitative aspect and commentary of the people that are part of this partnership. So our project, the MICA project, surveyed churches that we're engaged with, and we wanted to know what are your concerns? What are the health issues that you believe your congregation is facing? And by and large, the healthy lifestyle was very important. Exercise, diet, nutrition, the ability to have information about diabetes prevention, that really stands out. And then the second one was cancer risk prevention. And looking also at mental illness was pretty high on the list, and it's a topic of conversation very, very often amongst the congregations and in the community. I see Reverend Abney nodding his head because it's something that he raises quite frequently. And visiting the sick, that's another aspect that we're going to be continuing to explore, how we can partner with congregations concerning visiting members of the community that are here within this institution, and then getting more education about HIV and screening for HIV/AIDS. And how did the congregations convey that they would like these educational programs to be delivered? So by and large, the group meetings stand out. They just, that is an effective way for them, again, listening to them, to have the educational programs delivered. Some are interested in a newsletter because of the times we live in. Social media is important to them. Getting some information about augmenting the sermon, information about health care, and then some other issues that also emerged. So these are other issues that they wanted to have on the table: educating caregivers, depression, part of the mental health aspect, asthma, living wills, cost of funerals, senior homes, talking about prostate disease, again, the diabetes, Alzheimer's, parenting, that's a big one too, parenting, child development and family care, childhood obesity, learning disabilities in adolescents. And thus far, from early in 2015, these are the programs that have actually taken place within congregational settings. The MICA overview is really hours and hours of having conversations and having the opportunity to collaborate with leadership in the congregations and in the community about what they need, what they want, and how are we going to get there. And sometimes it's a slower process than other times, but the outcomes show that not only are they interested, but they committed to creating a platform where we can collaborate with them and come into the congregation to have this meeting.
The mic that you're going to do overviews looks like you have 56 occasions and almost 5,600 participants. So you basically have 100 people per session. Am I getting that?
Well, in some instances, if I went to a very large church, it was a larger number. And if I had an opportunity to speak in front of that congregation, that's good. I can tell that you're paying attention to Dr. Sharma. This is, to a degree, inflated when there's a very large congregation and I have an opportunity to speak. There's obviously more people at those events. They're all hearing the message.
But to your point, Zorina's doing this remarkable job. There are 52 weeks in a year.
Right.
And in less than a year, she has to do this 56 times to socialize it.
Right.
I think that's another part of this table.
So again, recognizing the importance, and we have to continue to stress that, the importance of faith-based organizations in health promotion. It's like we're at the top of a well, and we're just kind of right now skimming the top of this well. The power that faith-based organizations have. Partnering and envisioning the nurturing and the presence of religious, spiritual, faithful imagination and relationships to affect transformation and health outcomes by seeking the leading causes of life. So it's a paradigm shift. Instead of seeking out, in the medical model, the leading causes of death, kind of shifting our thinking towards what are the leading causes of life and how can we support those leading causes of life within a faith-based organizational setting. So 87 faith-based organizations and FBOs have attended the breakfast lectures, and those topics over time have included health prevention, disease management, access to care, and use of scripture to work with the sick. And this has happened sort of currently, that there's been this opportunity to work within the Mount Sinai system and the community on the district projects. There's delivery system reform initiative, payment restructuring that is happening throughout New York State. So what is district? It's one of the initiatives of the governor, the current governor, Andrew Cuomo. It's a Medicaid redesign team effort to transform the Medicaid program. It's an effort between the state and the federal government to improve health of the Medicaid population and the uninsured. So even though our program is not specifically for just uninsured or Medicaid community members, but because the state is doing this and Mount Sinai is part of this, this has become part of the work that I'm doing, working with the district team. So it is a performance-based, not a traditional, structuring of the payment plan, but hospitals are going to be, and already I believe are being required, and this is being gradually integrated into the financial structure of the hospital, hit performance goals before payments is made for the care of patients. So this is a map that was provided to us by the district team, and it shows that the Mount Sinai initiative serves 7 hospitals within the Mount Sinai health system in 4 counties. And we have 56 health centers, health center clinics, 58 care management providers, over 600 mental health and substance abuse providers, 78 rehab facilities, 11 hospice programs, and 53 community-based organizations. And recently, because I'm present there and raising the issue of faith-based organizations, now faith-based organizations are part of this, becoming part of the system. So the goals are to provide incentives to healthcare providers to build infrastructure and programs to improve population health specifically, expand access, allowing patients to receive care in the right place at the right time to maintain their health. And what does that mean? Expanding access means that recognizing that there are already community-based organizations in the community that are providing specific types of care. So it could be mental health, it could be a community health center, and recognizing that these organizations are part of this project and that they are valued partners as well, so that patients will not always have to come to the hospital for their services, will not always have to necessarily come to Mount Sinai, but they can go to these other community-based organizations and they can get the care that they need. And hopefully, in the long run, this will reduce admissions to the emergency room. It will reduce the progression of disease and the ability for the patient to have more awareness about their health and easier for them to get to some of their healthcare providers. So it should reduce avoidable hospital admissions by 25% by year 5. We're currently in year 2, so we have 3 more years to work on these goals and objectives. And we're trying to shift the payment system from volume to value. So that's the main restructuring part. Instead of fee-for-service, value-based payments, and by 2020, this whole, hopefully, the way in which the system is operating will be changed because 80 to 90% of the Medicaid payments will be value-based by 2020. And 35% of payments fully capitalized should be risk-based. So reducing the patients that are higher risk, like congestive heart failure, people with that sort of a diagnosis, and different formulas, and it's very complicated. I'm not going to tell you I understand the whole thing, but the main thing is that I'm at the table, I'm representing that faith-based organizations are valued partners, and we want to just continue that message. And so we're improving access to care, we're developing navigation services, developing a resource guide. That's still, it's getting better. It's been in a test mode for a couple of months. Call center referrals, the potential to train navigators. It's a very present conversation, and perhaps getting some navigators within congregations. Include congregations in the community resource guide as assets, and train congregations to access the call center resources. So the role of a healthcare chaplain as the community liaison, in this case, I'm basically talking about myself because I'm the only one doing this at the moment. Providing health education for congregations through the collaborations with the different departments in Mount Sinai, and in some instances with some of those CBOs that I mentioned as well. Helping congregations to develop wellness events tailored to their specific needs, helping them to have an pathway to access to health care, which isn't always a clear-cut path. Opportunities for programs on prevention and early detection, and collaboration with Mount Sinai and other community partners. This is what we're going to continue to do, sustainability. We know that over time, those breakfasts have been a key component to this whole process. We're going to continue that, continue to build relationships within the hospital. We established an advisory board and began meeting in 2015, and that board is made up of key leaders. Two of them are here today, Reverend Abney and Reverend Domingo Vasquez. Thank you for coming. Being able to attend worship services, so that can be myself and people in our department who are very interested in getting out to the community at time, on Sundays, times when people are not at the bedside, meeting one-on-one with the leaders, responding to requests, and I take that very seriously. I try to respond to these requests on a timely basis, but also not having realistic expectations about what we can provide within certain time frames, and learning about individual differences and similarities within congregations. So again, working within Mount Sinai, collaborating with community relations, engaging, providing resources to provide health, education, screening, and prevention, discussing potential improvement in access to care. This is an ongoing conversation, and inclusion of pre-existing population health programs with data that support measurable outcomes. And so the preliminary work was establishing of the micro-project, opening up the dialogue, observing which congregations seem to be a little more interested, because again, it has to be meaningful to them. It has to be meaningful to the leadership. It has to be meaningful to different ministries within the congregational setting. And then continuing to collaborate and co-create tailored health programs. And then again, responding to the requests. Usually ask that congregations give us at least 6 to 8 weeks lead time. It's much more difficult. I'm not saying it's impossible. It has happened where it has a shorter amount of time to help them plan a program, but really to get a provider, and people are very, very busy, and the providers are doing this in most instances in their spare time. They're donating the time, they're donating their knowledge and expertise to go in on a Sunday or a Saturday very graciously. And those who come forward enjoy being there and enjoy being part of the congregation while they're there. But we want to do this in a way that's really fair to both the congregation and to the providers. So improving access to care, we talked a little bit about this already, and helping to train, really help. It's going to be another process. I mean, that's a holistic project in and of itself. Some of the lessons that we've learned thus far, and this may be too small for you to see, but the advisory committee process takes time to develop and to build consensus. So we have leadership and representation from Mom on the advisory committee, from many ministry leaders, and a few pastors as well. Congregational timeframes and calendars have a life of their own, which pose a challenge in matching providers to needs. So because usually congregational calendars are set for the year, and also set by specific religious occasions and holidays. And those occasions have activities associated with them. So the congregation figuring out when do they actually have time to have a micro-project come into their setting. A large percentage of the time, as Phil looked and noted, is devoted to building and sustaining relationships. And this is really the only way this work can be done. There has to be opportunities to get to know people, for them to get to know me, for us to have conversations, for me to use my active listening skills as a chaplain to try to understand exactly what's going on. And then the engagement may evoke a historical narrative from the community. What is that historical narrative? They've had a bad experience maybe with a doctor, with a provider, with a hospital. And I have to be able to hold these stories, and I have to be able to try to help them to make sense out of it and integrate that with their healthcare needs. And so I think this is within the range of expectations that these stories should emerge. And congregations enjoy being affiliated with the hospital, and the leadership enjoys a safe space to discuss questions and interfaith dialogue. Questions, comments? I know it's a lot of information, but I enjoy any questions. Yes, ma'am.
Hi, Zorina, thank you for all your work. The question that I have, and I guess you've got some of your, the people that are involved with you here, is I work a lot in the ICUs, and I see a lot, especially a lot of patients who are in really late stage of liver disease, and a lot of them are, minority people of color, and it's like they're there, and the families are like, how did this happen? We just suddenly got here, and this person we need a transplant, and we kind of build an awareness. And I think we see a lot of focus on substance abuse, and I'm wondering if that is hand in hand, is that what in statistics with mental health?
Yes, mental health, it's not outlined here, but mental health and substance abuse are tied in many
It seems
instances.
like since the 70s or 80s, that has kind of taken the back burner in the community as something to focus on. Have you noticed that?
It really hasn't taken a back burner. There's the East Harlem Health Committee. They discuss this topic frequently. There's community meetings going on. It's discussed. Reverend Abney is the president of the 25th Precinct Community Council on that 25th Precinct on 119th Street.
Correct.
And so because of the crime related to substance abuse, particularly in this area, it's an ever-present topic that's being discussed, and that there are community-based organizations that discuss it and are addressing it. Now, whether or not people are going into treatment and programs, that's another story. And so some of the patients we see here may have gone years with disease undetected because they weren't going to a doctor, they weren't being followed up in a clinic. And I think that's some of the cases that we get here. It's very sad.
And total unawareness of
Yes.
Maybe looking at that from another direction, I think one of the things that we most have to do that the churches would help with is under medication for pain. And I think we see evidence coming out that not only are we under medicated for pain across the country, but particularly in the minority communities. And I think there was a recent thing that finds that a sizable percentage of medical students have the belief that African Americans were less sensitive to pain. We have a statue across the street that sort of demonstrates that historical narrative. And I think as we're concerned with substance abuse, we should also be concerned that perhaps the deacon's wife's arthritis is properly treated, and she doesn't have her autonomy questioned by a physician young enough to be a grandson. And I think that if the church has established a committee on pain management to advocate to the hospital, where they reviewed and supported their community people, where basically the congregation come to the minister, come to the committee, they will advocate that they get the proper level of pain medication. I don't think we have to worry that a large number of the older congregants are going to deal with their arthritis by becoming addicted to heroin, even though that might be a problem across the country with other communities.
Well, thank you for unearthing that. Actually, one of our chaplains, Rocky Walker, who was working specifically with sickle cell patients, he said the same thing. He said many of these patients are under-medicated because the doctors believe that they are just acting like they're in pain, more pain, so that they could get drugs.
Right.
They can be, and that was one of the things that he uncovered as a chaplain to sickle cell patients here at Mount Sinai.
Rocky schooled me in this issue, and I visited some of the sickle cell patients with me.
So I think I'm getting the nod from our Director of Clinical Pastoral Education that my time is up. Thank you so much for this opportunity.
Thank you, Zorina, for that presentation. I think this is one of the most exciting aspects of the Center for Spirituality and Health here at Mount Sinai, is this opportunity to be engaged with communities to help improve health in a mutual sort of way. So by way of conclusion, I would just ask, if you haven't had the opportunity to sign in, please make sure to do so before you leave. And if you have not filled out the evaluation form, please do that. And on your way out, please hand it to Heidi, who who will stand outside by the door. Thank you very much and have a great rest of the day.
Can I, if you didn't check in on the attendance forms, please do. I counted at least 32 people here, and often there's an undercount on the attendance sheet, and please also do fill out the evaluation forms, and I'll collect.
And CPE residents, if you want to take a break, please do so and return to this room in 15 minutes at 10:15, and we'll have a post-grand rounds discussion. If you're a CPE intern and would like to attend and have the time, you're welcome to do that as well.
I just want to thank you for coming. Thank you.